Hi everyone, my name is Dr. Ubaid Rahman, Assistant Professor from Department of Pediatrics. Today I'll be covering a topic of bronchiolitis. So bronchiolitis with the introduction, brief, most common serious lower respiratory tract infection needing hospital admission by the pediatric burden illness of worldwide category, and it is generally a self-limiting condition. It is basically a clinical syndrome with the acute onset of respiratory symptoms with less than 2 years of age predominantly. Initial symptoms will be upper respiratory tract infections, which is commonly caused by the viral infections. The upper respiratory tract infections will be fever, coryza, which progress for 4 to 6 days to lower respiratory tract infections leading to cough and wheezing. Epidemiology: increased incidence are due to more premature infants and the children with the chronic illnesses. More common in children less than 12 months, and more than 50% of affected children will be 2 to 7 months of age. Infants less than 6 months are at highest risk of clinically significant disease. 2 to 3% of the children require hospital admissions of a bronchiolitis diagnosis, and common in the late autumn and the early spring period. Predisposing factors: the infants in their daycare and exposure to passive smoke, crowding in the household, environmental and genetic factors do contribute to the severity of the disease. Etiology: most commonly it will be of viral etiology. In that viral etiology, the most common virus will be the respiratory syncytial virus, which accounts of 80 to 85% of bronchiolitis cases. The other virus will be influenza, parainfluenza, adeno and coronavirus and the rhinovirus. Mycoplasma pneumonia, though isolated, not recognized as a etiological agent. Pathophysiology: the major pathophysiology will be a slowed epithelial cells, neutrophils and the lymphocytes, which will lead to complete or partial plugging of some airways, and this leads to ventilation and perfusion imbalance. The next will be the airway obstruction, which lead to atelectasis or the word distension, which leading to the hypoxemia. The clinical features, it's quite variable with among the children. So the most common will be the nasal obstruction with or without a rhinorrhea. The cough will be the first irritating, and it will be of a tight cough, which is a dry cough initial stage. And poor feeding after the initial onset of the symptoms. Apnea up to 20% in less than 12 months of age group with respiratory syncytial virus. The fever will be of a higher grade. The next most severe clinical feature will be the respiratory distress, which is categorized as mild, moderate, or severe. The clinical feature of the respiratory distress will be nasal flaring, tachypnea, expanded chest, audible wheeze. Auscultation findings will be rales or rhonchi with poor air entry, prolonged expiratory phase. Other features will be conjunctivitis, rhinitis, and otitis media. The mild to moderate hypoxia, which will be done by pulse oximetry or arterial blood gas. The classification of the bronchiolitis will be mild, moderate, and the severe based on the ability to feed, respiratory effort, and oxygen saturation observed at the admission. Investigations: the complete blood count will be taken, then the chest X-ray, the nasal pharyngeal aspirate, which will rule out RSV and the other viral cultures, and electrolytes, especially if needing IV fluids. Blood culture if a temperature is more than 38.5 degrees Celsius, and the blood gases in case of respiratory failure or respiratory distress. Usually no lab test needed in case of mild bronchiolitis. Chest X-ray, which will be showing the hyperinflation, patchy infiltrates, typically migratory, which is of a post-obstructive atelectasis or pre-bronchial coughing. A diagnosis: it's a clinical diagnosis. The infant with a short prodromal of symptom of upper respiratory tract infection. The most common clinical finding will be audible wheezing, wheezing with the crackles, and the respiratory distress with the chest recession. Differential diagnosis which will mimic the bronchiolitis will be congenital anomalies, which is a vascular ring congenital heart disease, gastroesophageal reflux, aspiration pneumonia, foreign body aspiration. Management: the supportive care will be the mainstay of therapy. Moderately ill infants will be requiring supplementary oxygen. IVF in case of young infants will be tachypnea, partial nasal obstruction, and feeding difficulties. Role of bronchiolitis will be controversial. Can have a trial with a nebulized salbutamol and nebulized epinephrine or a hypotonic saline. Therapy, which will be of humidified oxygen, will be an ideal mode of treatment. The supplemental oxygen, if SaO2 is less than 95%, the combination of a clinical significant respiratory distress with a respiratory rate of more than 60 cycles per minute with the feeding difficulty. To maintain a SaO2 above 95% is the ultimate aim, and it can be the oxygen therapy can be given through nasal prongs, face mask, hood, or the head bags, depend upon the age of the patient. Hypoxemia with or without distress despite a high oxygen flow rate and the respiratory ventilatory support. Fluid therapy. The indication for the fluid therapy will be the nasal flaring, tachypnea of more than 60 cycles per minute, and apneic episodes and the marked retractions and tiring during our feeds. A normal maintenance volume is required, N2 or N bar 4 or the dextrosaline. The fluid volumes increase up to 20% if the frequent or the persistent fever of more than 38.5 degrees Celsius and or markedly increased respiratory effort. And the main effort during the fluid therapy will be monitoring of serum electrolytes. ICU admissions, PICU, they needed in case of a following category: the progression to severe respiratory distress, especially in at risk group. Next is apneic episodes. Example, they associated with the desaturation or more than 15 seconds duration or a frequent recurrent brief episodes. Persistent desaturation despite of the oxygen therapy. ABG evidence of the respiratory failure, that is PO2 less than 80 mmHg, of a PCO2 more than 50 mmHg and a pH less than 7. CPAP may benefit infants with the bronchiolitis by stenting open the smaller airways during the phase of respiration, and it also prevents air trapping and the obstructive diseases. Discharge. When a patient of a bronchiolitis can be discharged when there is a minimal respiratory distress and SaO2 maintaining of more than 90% in room air, except in case of chronic lung disease, heart disease or other risk factors, not received supplemental oxygen for more than 10 hours, then minimal or no chest recession and able to take oral feeds. Complications. Most frequent complication will be respiratory complications. The second most common will be infectious complications, and the other one which is rare will be the cardiovascular and the electrolyte imbalance. Complication rates were higher in case of former premature infants, congenital heart diseases or other congenital abnormalities. The infants of 33 to 35 weeks of gestational age and the highest complication rates with a longer hospital stay and increased cost than the other former premature infants. The serious complication will be respiratory failure, which will be one of the most common life-threatening serious complication. The other one will be apnea, pneumothorax. Among the former premature infants and the congenital abnormalities, the risk of serious bacterial infections in the first month of their life, regardless of a respiratory syncytial virus present or not. The prognosis of the bronchiolitis, generally it is a self-limiting condition. 2 to 3% of the children will be requiring hospitalization. Need for supplemental oxygen based on SaO2 on admission and predict the length of the stay. Beware of a rapid deterioration in a higher risk group, and death is uncommon even in the higher risk group. Thank you.